Welcome back, everybody. David here again with Med School Bootcamp. So in this next video, we're going to talk about something called slipped capital femoral epiphysis. Sometimes this is also abbreviated as a SCFE. So what is this? Well, this condition is also sometimes called juvenile femoral head detachment, and that essentially explains what it is. Remember that in the body, the longest bone is the femur. And at that long bone, we have the growth plate, or the epiphysis, that is actually a part of it, right? Remember in childhood, a lot of the growth that occurs at the epiphysis, and the epiphysis, or the epiphyseal plate, is essentially the growth plate. That's where a lot of the actual growing of the bone occurs. As you go through a growth spurt and you get older and taller and the bones elongate, this is the primary site where this happens. So if something happens to this area right here, that can obviously cause problems for patients later on. And the general idea here is that we have a slippage of the femoral epiphysis. That's really what I want you to think of. If this slips out of place in either direction, that can affect the overall growth of the bone in general. So that's kind of a big picture idea of what we're going to be talking about in this video. But if we think about the etiology here, this is a primarily idiopathic condition. That means we don't necessarily know why it always occurs. We do know that this typically is going to occur in an age range between 8 and 16 years old. And again, this makes sense to us. Why? Because this is where the primary growth spurts occur for most people. And this pathology tends to occur during those growth spurts. When the bone is undergoing an elongation process, this is when you're most likely to see this slipped capital femoral epiphysis. We do know that there are some risk factors associated with this condition, and those include things like endocrine disorders, specifically hypothyroidism, family history, obesity, and trauma. And so just to briefly unpack these endocrine disorders, right, anything that affects the hormonal response in the body can obviously affect it in a variety of different ways. And this includes the growth process. Family history, anytime we have a family history of something, kind of a basic principle is that you have a higher likelihood of having it going forward. When we think about obesity and trauma, these two have to do with specifically damaging the epiphyseal plate or the growth plate itself. Obesity is excessive force, excessive shearing on that area that can cause a slippage to occur at the growth plate. Similarly, trauma can actually manually, forcefully cause this to occur in an acute incidence. Now, if we think about the pathophysiology, ultimately it's due to poor growth plate development, which leads to an increased epiphyseal width and increases the risk for slippage with an inciting factor. So we kind of highlighted these structures right here, right? We have the growth plate, and you can even see it in this image over here. But what happens if poor growth plate development occurs? That is to say, there's poor maturation of the cartilage or endochondral ossification, which remember is one of the ways that bone actually grows, where cartilage is laid down and then bone actually replaces it. And this is the primary model by which long bones are actually formed. Well, if any of these things are not working properly and the growth plate is poorly formed, it increases the width of the epiphysis. This leads it to have a higher risk of these things occurring, and that can be due to endocrine disorders, right? Again, you have a higher risk predisposed patient plus the endocrine disorder. You have a higher risk predisposed patient with family history, obesity, or trauma that predisposes them to having slippage of the joint capsule. And so if these processes do not occur normally, we can get the increased epiphyseal width, and this kind of predisposes patients to have some of these things occurring. So now if they have an endocrine disorder, that might, along with the epiphyseal width, increase the risk for slippage and ultimately them developing a SCFE. Now, patients who have this increased width are going to have an easier chance or be at higher risk of the slippage occurring due to obesity or higher forces on the joint, or to trauma, which can be due to a shearing. So again, it's the increased epiphyseal width is kind of there, and then some inciting factor will lead to the slippage and actually lead to the pathology of SCFE. So again, patients will have an inciting factor. They'll often have one of these things up here, in addition to the poor growth plate development and increased epiphysis width, which ultimately leads to slippage of the bone itself. Now, if we think about the presentation, these patients will often present with an antalgic gait and pain in the hip, groin, or knee. And this is really important. We're going to talk about a few different pathologies here that can affect the hip in younger patients. But a key point that I want you to remember is that knee pain may be coming from the hip. So anytime somebody presents with knee pain, we need to look at the hip. Vice versa might also be true. If somebody has hip pain, they may be dealing with knee pain and they're just compensating for it. So the idea is you need a full lower extremity musculoskeletal exam to really determine what's the patient's most likely condition. Now, these patients are also going to have decreased range of motion, mostly with abduction and internal rotation. And so decreased range of motion can make sense to us, right? Because anytime you throw off this hip joint, right, anytime you change the alignment, it's going to change the biomechanics of the joint. So with decreased abduction, they have decreased ability to move their leg away from the midline. Recall, if this is midline right here and we have two legs on each side, abduction is going away, or abduction, and adduction or adduction is going towards the midline. It's actually making the joint angle smaller. Remember, adduction, you're adding things together. Abduction or abduction is doing the opposite. It's moving things away from the body. Now, patients may also present with what's called passive external rotation, where their joint will be externally rotated, or they'll have their foot kind of turned out rather than internally rotated, turned in. This again makes sense because they have a hard time internally rotating that joint. It's also important to note that this is classically unilateral, but it can be bilateral in 20 to 40% of patients. So be on the lookout for that. If a patient presents with new onset bilateral hip pain and they don't have any trauma, this could be definitely something that you'd want to consider, especially in a younger patient. Now, understanding the presentation for this condition is really important because there are several other things that can cause hip pain in a younger patient. So our differential might include some things like late Epiphysis disease, transient synovitis, or potentially even septic arthritis. You need to work up for these other conditions if somebody has this hip pain during presentation. So LCP, or late Epiphysis disease, we'll have a whole video on, but typically this is going to occur in a slightly younger patient. We talked about kind of the 18 to 16 range. Late Epiphysis, I think more in that 5 to 10-year-old range. Again, there's some overlap there, but these are just generalizations to keep in mind. And this condition is actually due to avascular necrosis, and you see a different radiographic finding. You're going to see femoral head lucency and flattening of the epiphysis rather than the slippage that we're going to talk about here shortly in this condition. Transient synovitis often follows a respiratory infection, a viral infection. This is a self-limiting condition that can also present similarly with that antalgic gait. But again, the history is going to be vital here. Also the patient's risk factors and physical exam as well. When we think about septic arthritis, these patients are likely going to present sick. They're going to have a leukocytosis. They're going to have actual infection in the body that is leading to hip pain. This is a can't miss diagnosis, so you need to think about it when you're doing these patients' workup. Now, when we turn our attention to the diagnostics here, the imaging is going to show widening of the joint space and posterior inferior displacement of the femoral head relative to the epiphysis. So if we draw our attention to our image over here, we can take a closer look. So just to briefly orient you, we have the femur over here, we have the acetabulum over here, and we have the epiphysis right here. It's kind of this growth plate line that you can see in the middle. Now, I want you to draw your attention up here, and you see that there is a slippage, right? This part of the bone has actually gone away from this part of the bone up here. These do not overlap. Typically, the bone would come up nice and easily right here, wrap around the head, and fit nicely into the acetabulum, but that's not what we see. We clearly see a slippage that is occurring, and this is a very classic image for slipped capital femoral epiphysis. Again, it's very nicely named for the slippage. It's a slipped capital femoral related to the femur, epiphysis related to the epiphyseal line. Now to wrap up this video, we need to talk about the management here, and this is really important because this will differ depending on the patient's actual etiology of their hip condition. So patients who actually have slipped capital femoral epiphysis, based on their physical exam, based on their history, and based on their imaging, they're going to need surgical intervention. And this is going to be pinning of the femoral head, where you actually go in with some pins, you realign the area, and you place a few pins in here so that the slippage cannot occur anymore in the joint. It's also important to note that these patients should decrease weight-bearing activities before surgery. Why? Well, we talked about weight-bearing activities can be a risk factor, and that can make the problem worse, so you want to avoid making it worse prior to getting surgical intervention. Additionally, the orthopedic surgeon may also consider giving the patient contralateral hip fixation. Why is that? Well, we said there's a pretty high risk that this is bilateral in patients. So if it's presenting on one side, it's pretty high risk, or it's a decent risk at least, that it could present on the other side later on. So this is kind of a prophylactic measure so that patients don't actually end up with this condition on the other side. And finally, it's important to consider some complications that can occur. So avascular necrosis of the femoral head is a big one. Anytime you have slippage that occurs, this can affect the vessels that actually feed the growth plate, the epiphyseal growth plate. That can ultimately lead to not enough blood flow and the bone dying. Additionally, patients can get chondrolysis, which is basically just degeneration of the cartilage. And finally, early onset osteoarthritis. These two kind of go together, right? Degenerating cartilage is going to give you a higher risk of developing early onset arthritis. So just a quick summary to wrap up this video. Slipped capital femoral epiphysis, sometimes abbreviated SCFE. We're talking about the femur, the long bone. Etiology is primarily idiopathic, but we do know it tends to occur kind of during the growth spurt in this age range and some of the risk factors that are involved. The pathophysiology here, poor growth plate development leads to widening of the epiphysis, which increases the risk for slippage. Presentation, typically going to be hip, groin, or knee pain with an antalgic gait. Range of motion is going to be decreased because we've kind of thrown off the biomechanics of the hip joint, and note a lot of patients can present with bilateral findings. Imaging here, we talked about kind of that slippage occurring. You can see the growth plate in the middle, and this is obviously off center. Management, surgical intervention for these patients, we need to pin the head. Sometimes this is done on both sides prophylactically. And the reason for this is because there's a variety of different complications that can occur if we do not intervene early. So how might this present on a question stem? They could ask you something along the lines of, a 12-year-old boy presents to the pediatrician with complaints of left knee and groin pain. On his way into the exam room, you notice an antalgic gait. The patient has no significant health history, but does report staying home from school 1 week ago due to an upper respiratory infection. Vital signs show slightly elevated blood pressure, normal heart rate, and a BMI in the 90th percentile. Radiographs show a displaced femoral head relative to the epiphysis. The question could then ask which of the following treatment options would be recommended for this patient's most likely pathology. Now, a couple things here. We have to think about the age of the patient. This is a 12-year-old boy, potentially in that growth spurt range. Patient was recently sick, so we can consider something like transient synovitis. But the key here is the radiographs show us that there is slippage, right? It shows us that the femoral head and the epiphysis are not well aligned, and this is very consistent with slipped capital femoral epiphysis. Additionally, the patient's BMI was in the 90th percentile, so that is a risk factor for them actually having this condition. The best treatment option at this time is going to be surgical pinning of the femoral head.